Welcome back to The Explainer. Today, we're diving straight into the ongoing Ebola emergency in the Democratic Republic of the Congo. We're dealing with a super rare viral strain, incredibly tough environmental conditions, and frankly, a massive race against time. So let's get right into the facts. Right off the bat, let's anchor ourselves with a pretty sobering statistic from the World Health Organization. Right now, there are 344 confirmed cases of this specific Ebola strain. And, we always have to remember that behind every single one of those numbers is a real person, a family, and a frontline community that is battling a severe health crisis right this second. So here's our roadmap for this explainer. We're going to cover the current Ebola outbreak, operating in a conflict zone, overcoming community mistrust, the testing and medical hurdles, and finally, the race for solutions.
Starting with part 1, the current Ebola outbreak and tracking the Bundibugyo strain. To give you a sense of scale, this outbreak is spread across 24 distinct health zones. It's impacting 3 DRC provinces, with Ituri acting as the main epicenter. That's where they've got 3 main treatment centers set up. We're also seeing active cases in North and South Kivu. And significantly, the virus has already seen an exported case into neighboring Uganda, which tragically resulted in a confirmed death. That cross-border movement is exactly why the WHO considers the regional risk to be exceptionally high right now. We've already lost 60 lives to this outbreak. But there is actually a small operational victory hiding in the data here. The number of suspected cases has plummeted from over 1,000 down to just 116. This is happening because the dedicated teams on the ground are finally clearing out these massive testing backlogs, which lets responders actually separate the true Ebola cases from other local illnesses. Moving on to part 2, operating in a conflict zone, or the logistics of chaos. Now, here's where things get incredibly tricky. To effectively kill an Ebola outbreak, the WHO absolutely needs to trace over 90% of a patient's contacts. But right now, they are stuck at just 45%. That means 55% of potential contacts are totally untraced, which basically creates invisible pathways for the virus to just keep spreading. And this 55% gap isn't for lack of trying by the health workers. It is directly caused by a compounding logistical nightmare on the ground. We're talking active armed conflict from multiple groups. You've got over 1 million displaced people moving rapidly to escape the violence, which makes the population highly mobile. Add chronic hunger into the mix, and then these blanket travel restrictions from other countries that are literally cutting off essential medical supply chains. It is just an incredibly complex web of security and logistical challenges. Which brings us to part 3, overcoming community mistrust, the human barrier. When the WHO Director General visited the epicenter in Ituri, he was met with this stark reality. Local leaders told him directly to his face that they believe Ebola simply isn't real, or that it's fabricated by foreign forces. This just highlights a profound, deeply rooted disconnect between the medical responders showing up in biohazard suits and the local community they are trying to help. And that presents an almost impossible dilemma that frontline workers face every single day. How do you treat a virus that people genuinely don't believe exists? Because if they don't believe in the disease, they aren't going to the treatment centers when they get sick. And that early window is the exact moment when care can literally save their lives. We really have to look at this with some empathy, This mistrust doesn't just come out of nowhere. It is born from their context. Alongside the rumors of foreign fabrication, there's a very real fear that the sudden flood of Ebola funding is diverting resources away from everyday killers like malaria and malnutrition. Imagine surviving Ebola only to die of malaria a month later because your local clinic ran out of basic supplies. Add to that the deeply ingrained cultural funeral practices that involve touching the deceased, which we know is highly infectious with Ebola, and the intense social stigma of even being seen at a treatment center. Let's pivot to part 4. Testing and medical hurdles, a rare enemy. So this specific Bundibugyo strain, it is incredibly rare. There was actually a massive 16-year gap between outbreaks of this specific virus. Because it essentially vanished for almost 2 decades, the global health community was totally caught off guard. Responders arrived without fully approved vaccines, without ready-to-go therapeutics, and without optimized test kits for this specific genetic sequence. And inside the medical wards, the complexity is just immense. In the DRC, malaria is everywhere, and its early symptoms, the fever, the chills, the fatigue, look virtually identical to the early symptoms of Ebola. So doctors are constantly dealing with superinfections. A patient comes in, tests positive for malaria, gets treated for that, but the malaria is actually masking a much more dangerous underlying Ebola infection. Finally, let's get into part 5, the race for solutions,
science, and solidarity. It's not all bleak. Looking ahead, there is a serious roadmap of hope here. In literally just 2 to 3 weeks, we're going to see clinical trials start for an oral antiviral called obeldesivir. Looking out 2 to 3 months, Oxford and Moderna will start their targeted vaccine trials. And in 7 to 9 months, IVI vaccine trials will begin. The global scientific community is moving at breakneck speed to adapt to this.
But while we wait for the science to catch up, there are immediate operational steps happening right now. First off, responders are aggressively decentralizing lab testing, pushing mobile diagnostic labs out to 5 super remote locations so cases can be confirmed instantly. Second, they're carefully integrating these new clinical trials into existing care centers. But the third, and probably most crucial step, is empowering community ownership. Since Ebola is a zoonotic disease that jumps from animals to humans, the local community absolutely has to lead the charge on safe hygiene and bushmeat practices to stop that spillover at the source.
Of course, pulling off a response this massive requires funding. To run this response for just the first 3 months, the estimated cost is $115 million. But right now, that requirement is only 35% funded by the global community. The responders on the ground are working way ahead of their resources right now, and they're relying heavily on global solidarity to close that massive financial gap. Dr. Tedros really hit the nail on the head when he summarized this. He said that science alone won't end this crisis. The true key to stopping the spread isn't purely biomedical. It requires local leadership, community ownership, strong partnership, and absolute trust. If the community doesn't trust the responders, the best medical tools in the world just cannot be deployed effectively. So I want to leave you with this provocative thought to take away from this explainer. The WHO is confident they will eventually stop this 17th outbreak. But as long as those deep-rooted causes of poverty, regional conflict, and zoonotic spillover remain, how do we stop this cycle from simply repeating itself next year with an 18th, 19th, or 20th outbreak? Thanks so much for learning with me today. Keep asking the tough questions, keep engaging with the facts, and I'll see you in the next explainer.